Hi, everyone. Thank you for joining me for Asep's Capital Minute, a look at what's happening in Washington right now that's affecting emergency physicians and patients. I'm Laura Wister. For the next 30 minutes, I'm going to give you an update of what's happening in our nation's capital, and then we'll open it up for questions. You can submit them at any time during my update using the Q&A feature at the bottom of your screen in Zoom, and then I'll answer them live after my update. So here's a taste of what we'll cover today, such as COVID-19 Provider Relief Fund and Uninsured Program, COVID-19 Relief Package 4.0 in Congress, the Dr. Lorna Breen Healthcare Provider Protection Act, ASEP's 2020 Voter Resource Center, and a preview of ASEP 20. We'll start off this week with an update on the COVID-19 Provider Relief Fund and Uninsured Program. The U.S. Department of Health and Human Services has continued to mishandle the distribution of the Provider Relief Fund, a $175 billion fund that was appropriated by Congress to help cover healthcare providers' lost revenues and increased expenses due to COVID-19. Over the last several months, ASEP has written repeatedly to HHS outlining issues with how the department has chosen to allocate the funds, as well as expressing concerns about the PRF's confusing terms and conditions and reporting requirements. Unfortunately, emergency physicians have only received a fraction of the total amount you've lost due to declining revenues and increased expenses since the pandemic began. And while we've asked HHS to allocate additional funding directly to you, HHS is not responding to our request and is instead sitting on approximately $60 billion of unallocated funding from the $175 billion fund overall. One major reason for this is that HHS tapped the Health Resources and Service Administration, or HRSA, which is primarily a grant-making agency with limited experience directly paying healthcare physicians and other providers, to allocate the funds, rather than CMS, which, as most of you well know, has extensive experience paying providers. The second reason is, as I mentioned previously, the Provider Relief Fund has such convoluted terms and conditions and other requirements that some healthcare providers are simply deciding it's not worth it to accept the funds. Or worse, providers believe that they are eligible for funding only to find out late in the process that they don't actually meet the complicated eligibility requirements. This can also help explain the difficult experience you as emergency physicians and other providers have had getting your claims reimbursed under the COVID-19 Uninsured Program. That program, which is also run by HRSA, is mainly funded by the Provider Relief Fund. The goal of the Uninsured Program is simple: provide reimbursement at Medicare rates for COVID-19 testing-related services, and treatment delivered to patients who are uninsured. However, complicated and inappropriate program rules have led to numerous denials for what should be legitimate claims, and physicians are not allowed under the current rules of the program to appeal these denied claims. So while HHS had allocated $12 billion to the uninsured program, less than $1 billion has actually been paid to providers. Last week, ASEP wrote a letter to Administrator of HRSA requesting that the agency make fundamental changes to the uninsured program to address the underlying issues that are causing all of these denials. In all, we requested that HRSA provide reimbursement for testing-related services when patients with COVID-like symptoms are evaluated in the ED, regardless of whether a COVID-19 test was actually performed or information about the test is included on a professional claim. Provide reimbursement for all ED visits where the patient presented with symptoms and or a diagnosis consistent with COVID-like symptoms as defined by the CDC. If you're interested in delving deeper into the issue, I suggest you check out today's Regs and Eggs blog, where ASEP Regulatory Affairs Director Jeff Davis covers this issue more extensively. While we're on the topic of COVID-specific provider relief, I'll provide a quick update on where things stand legislatively on the fourth major COVID relief package. Picking up where we left off in our last Capital 30-minute update in early August, the fourth major installment of COVID relief funding continues to remain stalled in Congress. While the first three major COVID response legislative proposals were approved by Congress with large bipartisan majorities, this round of discussions has proven to be much more challenging. The House Democratic version, the HEROES Act, included $3 trillion in funding and program support, while some Senate Republicans believe that even the $1 trillion included in the Senate Republicans' own version, the HEALS Act, is too much, and still others in the party are opposed to another funding package at all. One significant ASEP-supported proposal that was included in the HEALS Act but not in the House bill would provide liability protections for emergency physicians, other healthcare providers, businesses, and schools that arise from COVID-19. But nonetheless, the Senate is planning to vote on its roughly $1 trillion skinny bill next week, and negotiations continue between House Speaker Nancy Pelosi and Treasury Secretary Steven Mnuchin, but they continue to struggle to reach an agreement. ASEP is continuing to monitor the negotiations closely and is advocating to make sure the provisions most favorable to emergency medicine for both bills make it into the final version that's signed into law. Congress has just a few more weeks to try and push something through before the November elections. Otherwise, our best hope is to pass something during the lame duck session before the new Congress takes over in January. We do continue, though, to have some positive momentum in favor of passing legislation to provide resources for physician mental health support services. On August 22nd, the Dr. Lorna Breen Healthcare Provider Protection Act, or HR 8094, was introduced in the House by Representative Max Rose of New York. The legislation is identical to the bill introduced in the Senate at the end of July and is similarly bipartisan. As you may recall, Asep worked closely with the Senate sponsors of this legislation that will take major steps to reduce and prevent suicide and burnout and alleviate other mental health concerns that have only been exacerbated by the COVID-19 pandemic. The legislation is named for Dr. Lorna Breen, an emergency physician and Asep member who died by suicide earlier this year. Similar to the Asep-supported Coronavirus Healthcare Worker Wellness Act introduced by Representative Raja Krishnamurthy of Illinois, the legislation provides grants to establish or expand mental health support services and resources for healthcare professionals responding to the COVID-19 pandemic and initiates a comprehensive federal study into healthcare professional mental health and burnout, particularly in the context of the COVID-19 pandemic. The bill also creates mental health and well-being training programs throughout the medical training and education process, and it establishes a national campaign to encourage healthcare professionals to seek support and treatment. Next, we are 2 months away from the upcoming elections, and Asep has created new voter resources for our members. We've created a special tool to help you engage in the 2020 elections and beyond called the Asep Voter Resource Center, which is a nonpartisan tool where you can easily check if you are registered to vote, how to vote early or request an absentee or mail-in ballot, find out who is up for election in your area, and learn more about the ways you can get involved, including support for the National Emergency Medicine Political Action Committee, or NEMPAC. You can also share the tool with colleagues, family, and friends. But before we can see this election through, our focus will be on ASEP 20, our annual conference that we'll be hosting at the end of October. So I'll end today's update with a quick preview. This unconventional meeting will feature over 250 courses, plus special guest, Dr. Anthony Fauci. The ASEP 20 lineup is getting stronger every day. National Institute of Allergy and Infectious Diseases Director Anthony Fauci will provide his unique perspective from the epicenter of the pandemic to kick off the ASEP 20 opening session. Following his remarks, a panel of international emergency physicians will represent lessons learned, global response to COVID-19. There's never been a better time for emergency medicine to come together than at ASEP 20. But despite PANS being optional for this year's virtual event, it'll still be a great opportunity to learn important clinical updates from your colleagues, including a track of 14 courses on health policy, including one that I'll be a panelist for. You'll also still have a lot of chances to network and mingle at job fairs, happy hours, and virtual game nights to reconnect with old friends and make some new ones in a virtual setting. We'll also have fun crowdsourcing competitions, such as TikTok videos of tips and tricks, and a new speaker showcase in a March Madness style bracket. And then lift your hearts as we collectively take the time to celebrate emergency medicine's achievement at this year's unconventional annual meeting that'll run October 26th through October 29th. It'll be so much more than a convention this year, so I really hope you'll register today using the link on your screen. That wraps up our federal advocacy updates, so I'll start taking your questions. Remember, you can submit them using the Q&A feature of Zoom on the bottom of your screen. The first question, is there more that ASEP members can do to ensure that the PRF funds make their way to emergency physicians? I think at this point, it's sort of been all hands on deck on this issue, and there's a lot of people and organizations in the House of Emergency Medicine who've been advocating for this over the last 4 or 5 months. And I think really at this point, the best thing you could do is to reach out to your member of Congress and let them know that this is still a really important issue. That being said, the challenge with advocating to Congress on this, which we have been doing all along, is that Congress sees that a lot of the money still remains in the fund. Like I said earlier, I think 60 billion of it, million, excuse me. And that hasn't been given out yet. And so Congress is going to be pretty reluctant to, let's say, call for new funding in the next COVID package if HHS hasn't even been able to give away the kind of old funding. yet. So we're pushing it hard, but I think this is going to be a tough kind of thing to face. And I think there's a little bit that Congress is pointing at HHS as the issue, which I think is definitely kind of rightfully. And then HHS is pointing back to Congress and trying to say that they can't fix how this is given out without Congress acting. So it's a little bit of, everyone's pointing at each other. So it's kind of tied up in all the usual politics. Another question. Do we anticipate a chance to recoup some of this funding at a later date or as part of other efforts? I think there definitely will be opportunities down the road. I think once there's time to do kind of a look back at everything that happened and to be able to supply additional data showing the financial hit that emergency medicine took, and as well additional data to show the very valuable role emergency medicine has played during this pandemic, which I think is recognized, but having hard numbers and examples always makes a big difference on especially the legislative and regulatory side, because they want numbers to make the case. So I think as that continues, especially when we can get research and data from kind of non-partisan governmental entities like the GAO, that'll definitely help. And then I think we can make the case for additional things like either it's like safety net funding that's kind of retroactive to make up for what happened during the pandemic. But I think there'll also be opportunities to show the impact and that some of the shortcomings in funding had in terms of the ability for emergency care to be widely provided during the pandemic. And then hopefully we can get some kind of proactive safety net funding built in or increased so that this doesn't happen down the road again. We've got another question coming in. It says, I'm so proud to support the Breen bill. Will it be enough to change the current approach to physicians' mental health? I think on its own, it won't be the one thing that changes things, but I think there's a lot of work that's being done around not just the bill itself, but raising awareness around the issue. We've worked closely with Dr. Breen's family, who has been doing really amazing advocacy and has been raising awareness since she passed away. And I think there's a growing recognition about how some of these mental health challenges that physicians, especially emergency physicians, have faced all along, much less now with the pandemic going on. One thing that's in the legislation that we pushed hard to include is part of that study I mentioned, this large federal study that the legislation calls for. We'll look at the barriers for physicians to seek mental health treatment and support. And that includes some of the state licensure and credentialing barriers that we've heard so much from you about. So our hope is that the federal study will kind of legitimize these barriers that we've been trying to raise awareness of all along. And then there'll be further efforts once that's kind of legitimized or codified in law, basically, that it'll be states, for example, will take much more seriously this issue of like really intrusive medical licensure questions and kind of get around to fixing those. And then certainly we would hope that, especially if it's a federal thing, then there's a lot that could be done with hospital credentialing. For example, CMS has a lot of control over how hospitals operate by virtue of the Medicare conditions of participation, which are pretty strict rules that hospitals have to comply in order to be able to take Medicare patients and be reimbursed for providing care to them. And so that's a lever that the federal government can use to address this. The federal government can't force state licensure bodies to change, unfortunately, but they can at least highlight the issue. And then certainly I think they have some levers to address this on the hospital side. So we're really hopeful that, if we're able to get this passed into law, that there'll be some changes coming on this. All right. We've got some more questions here in the queue. You mentioned Representative Krishnamurthy, for example. How does support for the Green Bill complement support for other mental health legislation? So kind of as the questioner asked, there's several bills out there to address improving mental health resources for physicians and other frontline providers. And these shouldn't be thought of as like competing. It's actually, in a sense, the more that there are, it's almost better because it'll draw additional attention to it. And we have a better chance of these being included in maybe the COVID 4.0 package, if that actually happens now, or a lame duck bill at the end of the year. So if there's, let's say there was just one bill, you can get a bunch of co-sponsors on it. That's very helpful to getting that in the final package. But if there's several bills, then I think people tend to sit up and take notice. Like, this must really be a big, important issue. Let's put something in. And usually what they'll do then is kind of harmonize the language in the, let's say, 2 bills. Sometimes it's 3, sometimes it's 4, to kind of come up with a sort of consensus version that would then be in whatever that final package is. So if that were to happen, certainly because we were involved in crafting several of these bills, we would presumably be included in some of those discussions and be able to help influence those to make sure that the unique needs of emergency medicine are met. Let's see if there's other questions. I saw some here. Sorry. There is another question. Here it is. You mentioned another relief package is in the works. Is it realistic to expect a relief package before the election? You'd asked me this a month ago, 6 weeks ago, I would have said absolutely. Of course there will be. There almost has to be. A, because of the need, but B, because how can they go into the election? How can either party go into the election saying like, no, sorry, we didn't want to help everybody during a pandemic again. But it's actually, like, as I mentioned in my update, it's becoming sort of a stalemate. The Senate Republicans have their $1 trillion version, while the House Democrats have their $3 trillion version. The Senate Republicans are calling their bill the skinny bill. And I know Leader Schumer from the Democratic side of the Senate today sent a letter to Leader McConnell calling, what did he call it? He called it the emaciated bill. So it's not skinny, it's emaciated. So that doesn't exactly bode well for good bipartisan linking of arms and getting something passed. I think the closer what's happened is, instead of the elections providing additional kind of pressure or incentive for a package to be reached that they could then campaign on, it's actually turned into kind of a finger pointing tool for each side to point at the other side and say, you guys couldn't even get something done. The other party didn't want to help people in the pandemic. And so I think that is this sort of overriding concern, is that neither side wants to help the other side. Granted, they're shooting themselves in the foot too at this point, but that's sort of the reality as things get more and more close to the elections. And I think sort of the parties are feeling a lot of pressure to come out ahead in advance of them. Voter resources for emergency physicians are a great idea. Are there emergency physicians running for Congress? There are actually a couple emergency physicians running for Congress, and I believe we have information about them on our website at asep.org/advocacy. If we don't right now, I'll make sure that we have those up there at the end of this. But certainly, we always try to support emergency physicians becoming active, whether at the state level or at the federal level. And each year, ASEP actually participates with several other medical specialties to run a candidate school to help emergency physicians who are interested in participating in public service by running for Congress, learn kind of what's involved in that and how to go about doing it. So certainly it's something we are trying to promote to make sure we have as many emergency physicians in Congress as we can. Currently we have 2. So that's where that stands. Another question coming in. Okay, there we go. There's still a lot of misinformation out there, and it's on the Hill too. What are the biggest misperceptions about the specialty that challenge our advocacy efforts? That's a really good question. I would say the biggest misperception is that emergency visits represent a failure of the overall healthcare system. So whether it's some of the alternative kind of payment models that have been developed or value-based systems of payment, as we move away from fee-for-service, they count an emergency visit as like a failure or a penalty, right? And then the hospitals, there's a hospital readmissions. Hospitals can be penalized for patients being readmitted kind of too soon, quote unquote. And so the emergency visit to some people, I think to a lot of regulators, represents the failure. We're trying to make the case that a lot of the times it's actually an opportunity. It's an opportunity to link a patient up with follow-up services and make sure that they kind of get into the system when previously they haven't been. We have a lot of people who are uninsured or underinsured, so they've been avoiding care. And so when they finally end up at the emergency department, I guess you could say it's a failure of our healthcare system in that they shouldn't have had to, wait until then. But once they're there, it is a good opportunity to make sure that they're connected to as many services and programs as possible so that they don't have to do that again and can have some follow-up. Asep's also working on, I've talked before about it in the Capital Minute, our alternative payment model, the AUCM, and that actually would incentivize emergency physicians to do post-discharge care coordination. And I think that will, in and of itself, help turn away some of these perceptions. I would say one kind of much more simple, you'd think it'd be easy to turn around on misperception, is that emergency physicians many times, other than in academic medical centers, are not employed by the hospital. And it was actually really surprising when the whole surprise billing debate started to go in to speak with healthcare committee staff in Congress who are usually very well versed on all sorts of nuances of the healthcare system and regulations and laws, like extremely knowledgeable on it. And it was a surprise to them to hear that probably more often than not, the emergency physician is not employed by the hospital. And so we had to explain kind of the structure and how that works. And so that's actually has like a big ripple effect, not just on, let's say, surprise billing, but even the provider relief fund that I was talking about before. Every time Congress was working on that, every conversation we had about it, they would call every news article about it, would call it the hospital fund. It kept being the hospital fund. And we kept having to point out, if it really is just a hospital fund, emergency physician groups are not going to get any money. And then lawmakers were like, well, won't the hospitals just give it to you? And it's like, well, no, they will not. And we just had to explain that unless there's a structure that recognizes that hospital-based physicians are often independent of the hospital itself, that there'd be big problems. So we talk about this over and over again, and we try to explain it each time, but you'd be amazed how often it's forgotten, even by the same congressional staffers or members of Congress themselves. So that's something that I think does get in the way of our advocacy at times. All right, we have 5 minutes out, so I'm going to take the last question, which is... Oh, it was here. What is the status of surprise billing at the federal level? That is a good question. So for each of the kind of big congressional relief packages on COVID-19, at least the second and the third, there was a big push by those in Congress who had worked on this issue to get their version of the bill included in the package. And this is mainly Senate Health Committee and House Energy and Commerce Committee. And together they had a kind of legislative approach that Asep strongly opposed because it was largely benchmark out-of-network payments for emergency physicians at the median in network and for that individual insurance company even. And so that would be a big problem overall if it were ever to pass into law. So they decided to kind of jump on the momentum of large COVID-19 packages to try and fit that in each time. We pushed back hard against that. We had a whole campaign pointing out to Congress that now is not the time. And it was largely successful. I heard from individual congressional offices that they were kind of appalled that we even had to deal with this in the middle of everything going on that our physicians were facing. So that kind of was pushed back each time. They tried again for this COVID 4.0 package. Latest I heard, it's not going to be in there. Granted, there may not be a package altogether, but if there is a package, I doubt it's going to be in there. There's just obviously too much controversy around surprise billing for anybody like McConnell or Pelosi, I think, to want to endanger their chances of getting something through. So I don't think we need to worry about being in there. I think we do have to worry about it being in a year-end package. I think that's the easiest time for it to be folded in. And by December, it'll be a little harder for us to say, we're in the middle of a pandemic, or we're just in the middle of getting our arms around this pandemic and trying to deal with it. Now's not the time. That'll be 9 months in. And so I think that'll be, we'll just look a little disingenuous if we were to say that. Meanwhile, the news stories of patients who are getting quote unquote surprise bills because they went to the emergency department for COVID symptoms are going to start increasing. And so it's going to put the pressure on even more. So I think with that, we're obviously keeping an eye on it. We have a lot of kind of collateral advocacy resources that we have ready to go should this bubble up again. And I think I don't know that we can avoid something happening on it. Well, I think something could happen on it, something may not happen on it. I think it'll be hard for us to oppose any congressional action on it without kind of coming out looking a little too, I think, self-serving. We can't really say that, but then kind of get our white hat back and talk about everything we did during the pandemic. So they're just not the best message. So I think we'll try to shape as much as possible if something does come up. And then we'll see how it goes. But with that, I want to thank everyone again for joining us. And we'll be back here in 2 weeks, same time, same place. Thanks again.